Good afternoon, everyone. Welcome, and thank you for joining us for this seminar, Articulating Implementation Mechanisms to Optimize for Impact, Efficiency, and Equity. This is the final event of this year's Institute for Implementation Science seminar series. Recordings from past events can be found on our website, which is linked in the chat. A few quick announcements. This seminar is being recorded, and the recording will be posted on our website after the event. All microphones are muted, so if you have any questions or comments during the seminar, please enter them into the Q&A box, as there will be time for questions after the presentation. CHESS continuing education credits are available for attending today, and details on how to receive credits will be emailed after the event. I'll now turn it over to our Institute co-director, Dr. Maria Fernandez, for some opening remarks. Thank you.
Thank you, Ricky. And it's my pleasure to welcome Dr. Cara Lewis. In a minute, we'll hear an introduction by Dr. Bala. I've watched Dr. Lewis's career since she started, I think, in the field, and have just been amazed at the superstar that she's become. And I think that's reflected in the number of attendees today. So this has been a phenomenal series of seminars, and it's fitting that that you are wrapping it up for this year. Thanks.
Thanks, Maria. On that note, it is really my honor to introduce Dr. Cara Lewis. Dr. Lewis is the Deputy Director of the Center for Translation Research and Implementation Science, CITRIS, at NHLBI. Dr. Lewis was a senior investigator prior to that at Kaiser Permanente Washington Health Research Institute in Seattle, Washington. Dr. Lewis is an implementation science methodologist who seeks to influence change across a broad field of diseases, settings, and stakeholder groups. She has been a driving force in elevating the importance of implementation mechanisms, emphasizing how studying mechanisms of change may improve tailoring, optimizing, and scaling of effective implementation strategies. The topic of our presentation today, exactly on that, on optimizing mechanisms for impact, efficiency, and equity, and we're really looking forward to hearing more on that. She has pushed the field to focus on measurement quality to improve the field's research rigor and generalizability. Dr. Lewis also has served as president of the Society for Implementation Research Collaboration. She was the founding co-editor-in-chief of Implementation Research and Practice, co-editor of Practical Implementation Science, and has lectured extensively for implementation science training institutes. So a lot of experience there with reviewing papers and bringing important journals to the field of implementation science. Like all of you who have joined us, I'm really eager to hear your talk, Dr. Lewis, on this topic. With that, I will hand it over to you.
Well, thank you for that very warm and kind introduction. It's been fun growing up in the field with you, Maria, and others. I see some familiar names in the participant room, but also many of you I haven't had a chance to meet before. And so I really look forward to an interactive dialogue, and we'll be sure to save time for that. I will acknowledge that I wasn't sure sort of the scope of experience that would come to the room today. And so I'm trying to start with some level setting and in a more basic fashion, and then work our way up to some more complex concepts as they pertain to advancing the study of implementation mechanisms. So on that note, I want to make sure my slides advance. You should be seeing my disclosures, of which I have nothing to disclose, but I need to acknowledge that the contents of this presentation should not be construed as representing an official position of the NIH or the Department of Health and Human Services. If that's not the slide you're seeing, someone shout out and I will fix it. Perfect. Thank you, Dr. Bala. So I thought it was fitting to put one of my favorite implementation scientists' pictures up on the screen, because it was at an early career review opportunity when the study section was still called DIR, Dissemination, Implementation, Research, and Health, that I first started talking to David about implementation mechanisms. Because at the time I had some funding from the National Institute of Mental Health to study standardized versus tailored approaches to implementation. And that particular institute had moved toward a requirement that interventional studies have a focus on intervention mechanisms. And he and I were contemplating the relevance for implementation strategies and acknowledging that it seems a little more accessible or obvious, if you will, when it comes to, for instance, biological mechanisms of pharmacologic interventions. And how do we bring this thinking into the implementation strategy space? And so he and I have continued that conversation for, I think it's over a decade now. And I really liked his characterization of the field as he presented it in CIRC in 2017. The Society for Implementation Research Collaboration in 2017 had as its theme studying implementation mechanisms, opening Pandora's box. And how he characterized the field was in terms of decades, that in the 2000s, we saw a lot of study along the lines of answering the question, what got in the way? And so we saw this slew of barriers and facilitators, papers, wherein research teams were using all sorts of methods to describe what got in the way of a specific evidence-based intervention being implemented in a particular local context. The next decade, and here's just an example of one of the seminal articles of that first decade of the formalized field in terms of a determinants framework that we've now seen updated with user input. So the Consolidated Framework for Implementation Research, or CFIR, is one example of the curation of the barrier and facilitator examinations that emerged in 2009 initially. The second decade, we saw the question of what works being addressed, which implementation strategies work, and maybe how well. And an article that I'm sure you're all familiar with if you're spending time in the field of implementation science is this initial compilation of strategies for implementing clinical innovations in health and mental health. And since then, we've seen Byron Powell work with colleagues to put forward the ERIC compilation, which is the expert recommendations for implementing change, and 73, I think it was, discrete strategies were featured, and then they got organized by experts in concept mapping. And we've seen other compilations emerge since that time, but really what a contribution to move from what got in the way to what works to address those barriers. And now the field seems ready to double down on answering the question of, well, how does it work? Why? In what context and for whom? And Dr. Bala and I were just discussing a recent, I think recently accepted article, if I heard right, from her team around investigating mechanisms of implementation in survivorship programs. And my gosh, this work is hard. So no wonder, we're not seeing a lot of it just yet. And I'll feature a systematic review that David Chambers and others and I worked on over many years and was published in 2020, I think it was, systematically looking across the globe at studies that were trying to understand implementation mechanisms. And this was implementation mechanisms broadly cast, and we surfaced 47 studies in that global review, only 9 of which actually looked at the mechanisms of implementation strategies. So that brings me to my next slide, which is me sharing a bunch of squiggly lines to communicate the point that I can't help, especially in my new role, reflect on 5 to 6, 7-year studies that implementation studies that unfortunately lead to or yield null results. A great example of this is the tailored implementation for chronic diseases, a multinational study that took about 7 years to complete. And on the other side of it, there was no difference between the tailored and non-tailored arms. There was so much to be learned in that study, but we didn't find significant improvements across the different approaches. And so it's examples like that that have me and others reflecting on the promises and pitfalls of the field. And thinking about what are the practical implications of implementation science. And I have come to the conclusion, maybe inappropriately, so I look forward to the dialogue, but that if we slow down and articulate very precisely the causal pathway between point A, where we're aware that there's an evidence-based practice ripe for implementation, and point B, which is the implementation outcome of interest, be it fidelity or reach, that we might do better in terms of boosting our impact on the implementation outcomes we're centering, or at the very least, understanding why we didn't in the cases where null results are found. And if you read the intro article by Michelle Vensing for the multinational tailored implementation for chronic diseases, in there he suggests that the strategies in the tailored condition were not appropriately matched to the barriers, and that there was not a sufficient understanding of the mechanisms by which the strategies act to achieve the outcomes of interest. So with that in mind, and some other comments that I hear all the time, very frequently, this works here, but not there, and that there's no implementation without adaptation. I've grown my interest, if you will, in articulating causal pathways as a way to help us transport implementation strategies to new settings and adapt without compromising their impact. So you can hear lots of reasons why I think that studying implementation mechanisms is a promising approach for influencing the science and practice of implementation. So if you agree with this promise or possibility, how do we think about these causal pathways? How do we as a field conceptualize moving from point A to point B? And I borrow this graphic from Dr. Byron Powell. I just think it's lovely and summarizes it very succinctly. I think there should be, we should be more explicit in step 2 here. So let's get all on the same page in terms of some terminology. And I'll try to bring this to life. By this, I mean causal pathways of implementation strategies through a really concrete example. And I apologize, my 4-year-old gifted me a cough. Okay, so most of our start here at the end, implementation outcomes. They are the effects of deliberate and purposive actions to implement new treatments, practices, and services. And you're probably familiar with the implementation outcomes framework that Enola Proctor first put out. I think it was in 2009, updated in 2011, which very intentionally distinguishes implementation outcomes from service outcomes and client or clinical outcomes, and is depicted to offer, this cascading effect of outcomes on ultimately the clinical outcomes that I think we all care most about. In here, you see equity featured as a service outcome. I'll try to pinpoint opportunities for boosting our attention to equity and implementation science throughout the talk today, but also welcome discussion on that front. Many consider penetration as a critical equity-related implementation outcome because subpopulations might be missed in an implementation effort that surface a critical gap for implementation strategies to target. But also you can find a really nice update to the REAIM framework, which is another conceptualization of implementation outcomes that brings equity-centered questions into each of those outcomes. And so hope you'll look to that as a resource as well. So if this is where we're going, implementation outcomes, let's use the example of depression screening rates up to guideline standards, guidelines based on evidence of what is the necessary rate of screening in order, excuse me, to achieve the population benefits that have been observed in efficacy and effectiveness research. So how do we get there? How do we get to these implementation outcomes? Well, Our field has settled on implementation strategies, which some people think about as interventions, albeit at a higher level than clinical interventions, as the methods or techniques used to enhance the adoption, implementation, sustainability of clinical program or practice. And just to share some examples, the ERIC compilation put together 73 discrete strategies in their publication. We now know there are over 100 discrete strategies. They can be organized in lots of different ways, but one heuristic here is from the ERIC is to organize strategies in terms of plan strategies. So you see some examples showing up on the slide for plan strategies, educational strategies, which are very popular, financing strategies, which are less popular, maybe because they're harder to deploy. But in one of our studies, we found that it wasn't the number of strategies you used, it was the type, and financing was the most potent. Restructuring strategies, which are common, particularly in low resource settings. Quality management strategies, which draws a lot from quality improvement, but also other disciplines. And then the policy context. So with the coming back to the example, the implementation strategy is the method or technique to get us to our implementation outcome. If we're trying to increase depression screening rates to a guideline standard, we might deploy depression screening via the electronic health record using a decision support prompt. I want to acknowledge that in this graphic, the implementation outcomes are purposefully far away from implementation strategies. I would argue that although they're more proximal to our distal clinical outcomes, we really should be looking for a signal sooner than getting our depression screening rate up to guidelines. There are signals, there are observable behaviors happening that would tell us if our strategy is working as we intend it to. And this is a way for us to be more respectful of our community partners, our health system partners' time. And I argue would also allow us to fail faster and learn more quickly if we bring into play intermediate and proximal outcomes. So just to round out the concrete example, if you have a decision support prompt in the EHR, it might be working if a clinician endorses being reminded. And that's not trivial. We know there is alert fatigue. I think there's maybe an even more technical term for that, but that occurs. And so your strategy won't be working if they don't acknowledge being reminded. And if they're not giving something like a depression measure, you probably won't get your screening rates up. So here are some different ways of thinking about outcomes as you pursue the study of implementation strategies. Now, the next term I'll introduce or reintroduce for most of you is that of determinants of practice. These are our barriers and facilitators, enablers, or obstructors of targeted professional behavior. So although the implementation strategy definition didn't say this explicitly, I think we are often choosing strategies because there is a barrier that is known or that has surfaced, and we're trying to resolve the barrier, or we're trying to overcome it, or we're trying to sidestep it. So as I did with strategies, I will just feature a way of thinking about determinants of practice that is organized by levels, if you will: patient, provider, organization, community, and policy. And I have on the side here, and failed to put the appropriate citation, but Krause and colleagues from that TICD study I keep mentioning found 601 plausible unique determinants spanning multiple domains that needed to be or could be overcome to achieve their implementation outcomes of interest. So I've gone ahead and plopped this barrier in the middle of the causal pathway because of what I just said, that we're often choosing strategies to overcome barriers. And so for this example of depression screening, A barrier that we've heard about, it's a plausible, likely barrier, is the primary care physician has divided attention, a lot to do. And so if indeed that is a prevalent barrier, then a decision support prompt reminder might plausibly overcome that barrier and achieve the outcomes of interest. Now insert mechanisms, which are the reasons why change occurred or how change came about. It is a process, and it must complete this plausible path between a strategy, a determinant, and an outcome. It itself is not the barrier, but it should be conceptually linked, and it is a process, not a state. So the mechanism here, I'll just offer you a label for a process that explains how the strategy works to resolve a barrier and achieve outcomes like the implementation outcome of interest. So here, an EHR embedded decision support prompt could enhance the salience, that's the mechanism, to overcome the barrier of a divided attention among a primary care physician and achieve the proximal, intermediate, and implementation outcomes of interest. Now, how often have I actually seen education, a community or a continuing education unit, as the strategy being used to try to activate enhancing salience and overcome divided attention? If you work that through a causal pathway, it is not so plausible. And so that is one of the benefits of slowing down and parsing and thinking critically about how strategies work, for whom, when, why, and why not. So in essence, it's checking your assumptions by drawing out the various factors in an implementation causal pathway. So our team thinks about these as the trunk. It is the basic causal pathway. And in doing so, we're often featuring impact here. So we're looking at the impact or effect of the implementation strategy, but you can feature equity-centered implementation outcomes. So I've changed the content here to feature reach or penetration as the implementation outcome. And the strategy should look really different, especially if one of the barriers is having the PHQ-9 in different languages made available. And so the strategy would need to activate ease in accessing other languages in order to achieve the outcome of interest. Now, I want to acknowledge there's nothing special about the shapes in this causal pathway diagram, except in one iteration, we did change the barrier to be a stop sign. Isn't that cute? Yes, it is. But you could just do it in a simple table. So you could place the implementation strategy in the first column, articulate what you think the mechanism is. I pick on education all the time because I see it being thrown around. It is resource intensive, both to create excellent education modules, but also to attend and participate in them. And when we acknowledge that their mechanism is perhaps limited to awareness building and also perhaps knowledge acquisition, we can be a little more realistic in terms of acknowledging that the determinant it might overcome is a knowledge deficit, and that the implementation outcomes, the farthest it could reach there is maybe adoption, but certainly not fidelity or sustainment. I'll unpack this whole table, but not spend time on it. Not too much. I just try to offer other examples that are looking at different levels of implementation strategies. Maybe I'll feature train the trainer. We see so often sustainment is undermined by turnover. And so train the trainer can embed expertise as a way to achieve sustainability of an evidence-based intervention implementation. So let's see here. Moving on. The other elements of a causal pathway that I think are important, and I think that these are perhaps the most important when it comes to equity in particular, are preconditions and moderators. So I'll start with preconditions, which are factors that are necessary for the mechanism to be activated at all. And that they need to be in place for the subsequent causal events to occur. And I borrow the analogy that Dr. Brian Weiner shared with us. Preconditions They're like your typical light switch. It's either turned on or it's turned off. And I talk about these as being particularly important for equity purposes because I can't help but notice implementation strategies that are being tested and deployed are becoming more and more complex and costly. And when we think about low resource settings where underrepresented individuals might be seeking services, we might not have the same resources available to deliver something like practice facilitation with fidelity. And so being very clear when you're designing implementation strategies about what the preconditions are can help people who might benefit from the implementation strategy that worked in your study. It might help them understand, can we even take on this strategy? What would it take to deploy it so it has any potential to realize the outcomes of interest? And so in this example, the prompt must be noticeable for it to actually activate the salience and address divided attention. And PHQ-9 or depression screening forms must be available, or in the case of the REACH example, available in different languages. I mentioned that a second factor on the causal pathway is the moderator, and Brian Weiner thinks about these as dimmers. They either increase the impact, or dim the impact. And it is a statistical term, but I think about it in a pretty practical way here. If you're aware of what moderators are, you might be able to design your strategy in a way that it actually leverages an enhancer. And so bringing it to the causal pathway diagram, we have habituation to prompts as a moderator that dulls the effect. And the clinic visit length can also make it less likely that you're going to be doing a depression screen. I'm not moving my arms enough when I talk, so my light went off, but I think you can see me still. So on that note, we've rounded out a causal pathway diagram. If you're interested in building these in particular, you can see some of our team's publications, the first in 2018, and more recently, Rosemary Messa's paper on Theorizing is for Everybody builds off Roman Kislov's excellent work with Paul Wilson and makes it pretty accessible in a practical way. And so I hope you'll look to that as a resource. And then I'm delighted to say that this team here, without me, they don't need me. They're moving forward with this National Cancer Institute funded R01 and are wrapping it up to offer you 30 causal pathway diagrams of the most commonly used strategies across a couple of the NIH institutes. And I think that will be an amazing resource to the field, along with measures of mechanisms that they've developed through a very rigorous process. So some resources forthcoming. I actually already mentioned the results of the systematic review to you, so I won't repeat them, but will acknowledge that the results of the systematic review led us to believe that there's more we could do to set the field up to be able to study implementation mechanisms. So we got an R13 funded from the Agency for Healthcare Research and Quality. This is a conference grant award, and we received 3 years of funding, which went over 4 years because COVID hit in our second year. So we actually just submitted the results of this, and I'll tell you a little bit more about that in a moment. The first step we did, though, was a multifaceted brainstorm process to surface. I think it yielded 105 discrete challenges to doing this type of research. And when it was moved through the Mechanisms Network of Expertise, which is a group of individuals primarily US-based who have been trying to advance the study of implementation mechanisms. Those 105 challenges shook out into these clusters. The super clusters included theory, causality, and context, conceptualization and measurement, accumulating knowledge, methods and design, as well as strategy, mechanism, determinant, outcome, linkages. So, so those were the challenges that we saw for the field, and since then have turned that into a research agenda. And not only a research agenda, but I'm delighted to say that when you bring together several nerdy academics who want to advance the study in something. They can't help but leave and write some really useful papers. So these two are already published for you and available in the special collection that spans the Biomed Central journals. The special collection is Advancing Science and Practice Through the Study of Implementation Mechanisms. Kudos to the implementation science editors for rejecting the main paper of this special collection at the desk, and we'll still be looking for a peer review opportunity for the research agenda, hopefully to come your way in coming months. At this point, I wanted to, I think it's repeat myself, but maybe say in a different way why I think studying mechanisms of implementation are important for practical reasons. I definitely don't want to be perceived as dancing on the head of a pin, but rather looking to maximize public health impact. And so selecting implementation strategies is our first task when we go to design an implementation plan. And there are some tools that can help us do that, but none of them are particularly precise. When you force someone to sort of think aloud about their process, I've heard people say they consider levels of strategies, categories of strategies, levels of influence for the target. But ultimately, what I think people are implicitly doing is trying to select them based on their mechanisms of action. So here is a totally different example for you, but I guess similar because we're still talking about screening rates. But in this case, the barrier for HPV screening that a team articulated based on diverse and representative patient groups is risk perception, believing that they were at risk, excuse me, for cervical cancer. And so in order to address risk perception, we really need to personalize the risk. We need to make it feel like it's relevant for a given individual. And so strategies that you could deploy to activate that mechanism could be provision of data, could be testimonials. But if you didn't isolate that barrier and articulate the mechanism, you might take a really, really different approach to trying to up HPV screening rates. Now, in addition to a practical challenge of selecting strategies, this is very, very much related, but really pushing on that matching, that idea that you're trying to overcome a barrier or sidestep it or resolve it. So here's another example from one of the implementation science centers I was a part of. There was a team trying to increase breast cancer screening rates in African-American Black women. And the barrier, there were at least two that emerged, excuse me. One was trust. And they told us they were going to use the chat bot to increase screening rates. And then they told us that trust was a barrier. And I kind of got confused, to be honest. I was trying to make that plausible link between the strategy and the barrier. And when we got around to articulating the mechanisms with them, they made a convincing argument that the chatbot could actually do well to validate concerns of people in a real-time personalized way. So that was their hypothesis that they were testing, but also a barrier was ease of scheduling. And so that was the other reason why chatbot seemed like a really good strategy to test, because it could surface appointments also in real time. You hear a lot about tailoring implementation strategies. So tailoring the form of it to the local context, because even within one health system, the different hospitals or clinics look really different depending on the physical structure, the staff composition, the size, the patient population, et cetera. So how do you do this process of tailoring if you're not thinking about mechanisms? I would argue that you need to retain the strategies, mechanisms of action in order to refine the adaptable periphery, if you will, or the form of it. So here's another example going back to the depression screening. In this case, an accurate knowledge of performance was the barrier. It wasn't divided attention. It was that a lot of physicians thought they were doing excellent in terms of their depression screening rates. Well, we know that audit and feedback works through highlighting a performance discrepancy. That's kind of its job, its process. But if you want to tailor audit and feedback to particularly low resource settings that might not have an electronic health record, it really needs to take a different shape. But if you know you need to retain this process of highlighting a performance discrepancy, you can change the shape of it. It doesn't have to be in an electronic health record dump, of data that is then fed back to clinicians. So the last practical way in which I think implementation mechanism articulation is useful is to optimize. And so I do think about this through the multi-phase optimization strategy, a la Linda Collins type of thinking in terms of optimizing for effectiveness, affordability, scalability, and so on. And the example here is an ultimate implementation outcome of service penetration is being sought, and the barrier is low practice change capability. There's a group you're working with that just doesn't have the experience of going through a change of a size or nature, and so the means, motives, and opportunities need to be enhanced. That's the mechanism. Practice facilitation is really great at enhancing means, motives, and opportunities. But practice facilitation is really, a complex implementation strategy. And some of the facilitation activities are listed here for you. Wouldn't it be nice to optimize practice facilitation to its core and to clarify the mechanisms? And Amy Kilborn and colleagues have done just that, and kudos to them for their excellent work in the publication in the special collection that I mentioned. So I'll wrap with maybe just a little more featuring on the equity front and why this, causal pathway depiction can be perhaps useful there. It can help you think about outcomes through the lens of equity or centering equity-specific outcomes. When I think about barriers to what? What types of barriers? If you're taking an approach that is equity centered, the answer to those questions might be really different. When I talked about preconditions, I mentioned already that the resources, the capacity, the contextual factors of a given organization or setting really matter. But when you're selecting strategies, and if you're thinking about preconditions through an equity lens that centers those aspects, and then also the contextual factors, but also the mechanisms. I think some would suggest it's still an empirical question as to whether or not mechanisms operate differently in different contexts. And so I hope some of you will take on that research. At this point, I wanted to overwhelm you with the progress of the field that I think is related to what we just talked about. And these are just snips from article titles that impress me and that I hope come together to advance the next generation of implementation strategy testing. So from what got in the way to what works to how does it work and what works for whom, when, and under what conditions. I talked to you about causal pathway diagramming today. I briefly mentioned theorizing, but there's more to be said on that front. Logic models are on your radar, and J.D. Smith and colleagues put forth the implementation research logic model. And Elvin Gang and his colleagues are really doing a lot on the mechanism mapping front. I put these on the same row because they're similar but different. These do not serve the same function in your research, and I really hope the field grapples with how do we bring these together? When do we use these different tools, these different approaches within our implementation study, and for what purpose? We also have different approaches to strategy specification from the Canadian group led by Justin Presseau, and then strategy reporting recommendations. This is but one example. We know there are more that Anola Proctor and colleagues have put forward. Brian Mittman, who I think is with us today, and I hope will dazzle us with some of his ideas around form versus function. Core components and the adaptable periphery is also really central to how we think about developing, testing, refining, tailoring implementation strategies. And you heard me mention MOST, which is frankly underutilized in implementation science. There's a special collection at the journal Implementation Research and Practice that is a call to action for the field. They're not getting many submissions because not a lot of people are bringing MOST to implementation science, even though it seems oh so relevant and useful. And then just to finish up this slide by saying that when we think about implementation strategy, development, and testing, we are also thinking about things like fidelity, consistent adaptation, strategy modification, and strategy tracking, tailoring strategies. And to the strategy tracking, here's an example of something that's recently come out, maybe not even published yet. I think that was a screen grab I did from the last conference that that Academy Health hosted for us. So I wanted to end the scientific component there and move into 2 slides to wrap us up. The first is just to acknowledge that I sit in the Center for Translation Research and Implementation Science. There are a slew of funding opportunities on the street. That's the technical lingo from NIH these days that you can find on our website, or you can email me about, and we hope that you will consider submitting applications to NHLBI, the National Heart Lung Blood Institute, with your implementation science ideas. We are signed on to this program announcement that many of the NIH institutes are signed on to. And don't forget that program officers, they are paid to do technical assistance with you. And so don't be shy, reach out to myself or our team to see how we can help you think about your implementation science application, find a good home for it, and provide technical assistance as you pull it together. Also happening, excuse me, within NHLBI is a 75th anniversary this year. And so there's a refresh going on for the strategic vision, what's important for NHLBI to invest in the next many years. And so hopefully you had a chance to contribute your responses to a request for information that was open for a couple of months in the fall. But if you didn't, you can tell us what you think is important in the areas on your screen or in areas not on your screen. And at the same time, Citrus turns 10. So we are thinking really carefully about what's next and are excited to work with you to really advance the field and practice of implementation for public health impact. And if you're not satisfied with doing that in your current role, perhaps as a grantee or aspiring grantee, then come join our team. We are hiring 4 folks for our center, an implementation science branch chief, and 3 health scientist administrators, which are program officers. And the application window is open right now. It closes very quickly. So pull your CV together, reach out to me if you have questions about these roles, and I hope to hear from you. On that note, I will stop my screen share and look forward to discussing.
That's great. Thank you, Dr. Lewis. And a really interesting, thought-provoking presentation with all of those figures. And even though I know that I will have the slides available to me, I already have the slides. I was taking pictures. Well, maybe we'll start from the last question up this time. And in fact, one of our attendees said that the paper that was lists, it's already published in IS Communications a month ago. So just FYI. All right, the first question here is from Kirsten Ostad. The field I work on, which is improving hospital discharge process, has a variety of evidence-based practices that range from didactic approaches, such as nurses doing a teach back, to complex multi-component interventions. For example, teaching before discharge, illustrated med calendar, call 48 hours after discharge. I struggle with how to separate out the evidence-based practices from implementation strategies, since they were not designed with this framework in mind, and wondering if you think you can hybrid map intervention and implementation strategy mechanisms.
Yes, and as soon as I hear the word map, I think Maria's also here, so feel free to chime in from an implementation intervention mapping perspective. But This is such an interesting and complex issue, and I won't grapple with the concrete example in real time, but happy to do so with you offline. It brings up so many related points that I think are important to touch on. But the direct answer to your question is yes. I think you can map both the intervention and implementation strategy simultaneously. I think that can be very appropriate. When I joined Kaiser Permanente and started working with their learning health system, I saw more often than not, there was this bundled designing of health system interventions and implementation strategies. And that made good sense for their heterogeneous but relatively homogeneous settings that they were working in. And so there wasn't really an important need to pull them apart until there was this one PCORI funded study that I participated in as an implementation scientist that wanted to take their approach to shared decision making for bariatric surgery into the UPMC, University of Pittsburgh Medical Center, which was a very different setting actually. And all of this to say that this implementation study funded by PCORI demanded that we pull them apart because the strategies that they used in Kaiser didn't exist maybe at UPMC, or they did, but did you need them? And what was the most parsimonious approach? And so I surfaced that because there are lots of reasons and times when it is really important to disentangle strategies from interventions. And it's not that that's always the case. So I gave an example where it is important. I'll give another example where it is important. I think for growing the scientific field for then practical purposes. For instance, if you expect your study to show up in a systematic review, but you haven't parsed the strategies from the interventions, it just won't get picked up or coded in the same way, or you've made a lot of work for the people doing the systematic review to make it so. But also just building the evidence for discrete strategies. We still need to do that. Even though I'm saying, let's look at what works for whom, when, how, under what conditions, we still need discrete strategy evidence base. And if we're not pulling those apart, it's really hard to then accumulate knowledge, whether it's systematic reviews or otherwise. I have more thoughts on this, but I'll stop so we can entertain other questions.
Yeah, no, that's a great point, and a really important distinction for practitioners in one system versus researchers who are trying to develop generalizable knowledge. So fantastic. All right, another question here is, in a lot of mechanism literature, the mechanism is depicted as an unpacked series of steps. For example, the one you gave of enhancing salience. The mechanism for that might be the prompt containing the keyword appears on the provider's monitor, the provider sees the monitor when entering, blah, blah, blah. The salience of the strategy is enhanced in the provider's mind. Decomposing the mechanism in this way can help us catch potential pitfalls. So my question is, does leaving the mechanism packed versus unpacked help, or just confuse matters?
Sure. And so everyone's favorite answer is it depends. And kind of like what I was just saying, it depends on what the purpose is. So like in our team's work to articulate causal pathway diagrams for the larger field to test and use, we had to agree upon a level of abstraction, if you will. What are we satisfied with in terms of a label or a process or steps? And we decided to stay at labels because that would be easier to generalize, speak about across settings and disciplines, for example. But when it comes to actually then deploying a strategy, I think that unpacking a mechanism into its processes is important. But also perhaps as you advance a particular strategy's evidence base, audit and feedback is a fantastic example that is the most, I think, studied implementation strategy, and yet there's still so much to learn. And when we took on audit and feedback as one of the strategies for which to develop a causal pathway diagram, the mechanism articulation was one of the more limited but growing areas for that particular strategy. And I think as that group of researchers develops the evidence base for that strategy, getting deeper into a level of abstraction might be really important.
Yeah. All right, another one here. As randomization and intervention development and assessment is not always ethical, particularly in health equity settings, I'm curious if you have what your thoughts are on how understanding implementation mechanisms can improve robust understanding of interventions. Note, I have in mind the situation of rehousing programs with unstably housed youth, but I know there are other similar situations.
So the question was that certain designs like randomization are not ethical or welcomed in certain settings. But what was the specific
Yeah, the
question?
question is, what are your thoughts on how understanding implementation mechanisms can improve an understanding of interventions in that context?
Sure. So my take on it is that we can do some of this kind of basic science around implementation strategies in analog environments and not burden our practice community with trying to make sure we understand, like, how does that education strategy work? How does audit and feedback work? We can do this in a simulated environment, for example. And so I say that because if we get real crisp that there is a signal and promise of a strategy activating a particular mechanism, and it can be paired to address or resolve a particular barrier, then when you're in a low resource setting and you're striving for equity, you can feel much more confident in the strategy you're selecting, that it should realize the impact that you're designing it and deploying it for. So I hope that begins to answer your question, but all of this to say that we should be selecting, matching, tailoring our implementation strategies. To do so, mechanisms might really help us there. And if we do that type of mechanism articulation offline or in other settings where we have the opportunity to bring in some rigorous design, then when we get into more low resourced or pragmatic contexts, we're more precise.
Right. This next question, Dr. Lewis, I think you might have mentioned it in your presentation. Is there a catalog of expected or purported mechanisms of actions of strategies? A list of expected mechanisms according to strategies that we can use to empirically test?
Yeah, that's a good question. So I have to acknowledge the amazing work of Susan Mickey and colleagues in the UK. So if you're not familiar with the behavior change wheel, or if you are in COM-B but you haven't seen their tools and techniques website, it's pretty impressive. They have a matrix where they list the behavior change techniques and putative mechanisms. And so that's kind of, I think, the map that this person is asking for. We really grappled with this when it came to our R13 research agenda, and we ultimately decided it wouldn't be wise to put forward a list of mechanisms, but rather more of these strategy mechanism barrier pairings, so that there's a starting place for empirical testing. So I'll leave it there.
Great. Somewhat related, is there an updated article to view these 100 plus strategies you referred to?
Yeah, I can get that reference. It's not, it's the EPOC. I think I'm saying it right. The Cochrane review has the 100 plus, and there's other places where these live, but the ERIC group hasn't updated their work in the last decade. So that's just a call to action for Dr. Powell and colleagues who might be listening.
Yeah. Yeah, that would be useful to everybody. Rebecca Peterson says, one framework that has been useful to me when leading professional learning or consulting to help teams select and use interventions or innovations is NIRN's Hexagon tool. Have you considered the work of the NIRN team in your work, which is a National Implementation Research Network at the University of North Carolina?
Yeah, so that was one of the Dean Fixon. I could see the colors of the first page in 2006, the monograph, first thing I ever read for implementation science. I mean, what a field shaping group that group is. They use a lot of quality improvement in their implementation research and have so many practical resources. So I'm glad you found some that worked. We did not explicitly interface that their tools in with what we've been developing. But as you heard me call for, the next generation of implementation strategy is how do we bring these resources and different approaches that have different purposes together for clarity and an ability to address the inherent complexity of the science that we do.
Yeah, and there are many others such as that in different substantive areas, and so it's really nice to have those resources. Here are a couple questions from James DeCarly, who introduces as I'm a cognitive neuroscientist and public health professional. I develop behavioral interventions to improve prevention programs. Can you please comment on the importance of outcome evaluations to provide sustainability of programs, both for implementation outcomes as well as programmatic outcomes?
I think if I'm understanding the question, it's maybe pushing us in the hybrid effectiveness implementation space. And if I got it wrong, please clarify in the Q&A or the chat, or feel free to follow up. But that's a really interesting issue of its own, right? You could extend these causal pathways that I showed today all the way to clinical outcomes, which I didn't, not just because the screen is small, but because we hope that it really does hold that our evidence-based interventions with demonstrated efficacy or effectiveness continue to have their impact if they're implemented with fidelity. But we all know that intervention adaptation, that's an implementation strategy, and it happens oftentimes in the work that we do. And so that's why hybrids can present such a useful opportunity for a study type. And at the same time, what incredible resources those demand, if we're being honest with ourselves. They're more costly and they have more of an impact on our practice community and partners to take a hybrid approach. So I really just hope folks are clear about when clinical effectiveness really ought to be featured in a study. But I heard in the question that it might be important for demonstrating to payers of the local context that would then lead to sustainment. And I would map that causal pathway out and make sure that that's the strategy you need.
Yeah. All right. Just last question here. What are the differences between intervention strategies and implementation strategies? Do we need two separate theoretical frameworks to guide the intervention development, adaptation, and intervention implementation respectively?
Well, this is a hot topic, I'll say. If you haven't listened to it's called This Implementation Science podcast. Doctors Mike Pullman and Kevin King out of the University of Washington kicked it off last year or so. Check it out. It's really, I think, a fun listen on a commute. I mention it here, though, because they hosted a group of us recently to grapple with the exact issue you just brought up in the Q&A here. And they recorded it and will put it as a group, as a podcast forthcoming. So I can't steal their thunder and tell you the answer to that question today.
Well, on that note, I want to thank you very much for really an amazing presentation, very thought-provoking, really advancing our understanding, and for me, frankly, providing more clarity in the field as I think about applications in many different areas. And also really thank you for leaving so much time for discussion and all of the great questions that were in the chat box. I want to thank the audience. We still have 252 people signed on for taking the time and really participating in our seminar series over this whole fall timeframe that we've started from September through now. It's been a phenomenal set of speakers, and I personally feel like we've really advanced our understanding of implementation science over these months. Everybody stay warm, and thank you for joining.
Thanks for having me, folks, and for the rich dialogue. Don't hesitate to reach out if you have questions or comments. And thanks for hosting me.
Our pleasure. Thank you. Have a great day, everyone.